Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 51 of the OBGYN podcast. Today is the Journal Club for February 2019, and joining me today is Dr. Oystein Bergoy from Norway. Welcome, Oystein. Thanks for joining me.
Thank you for having me.
So before we get into today's podcast, I wanted to say thank you to everyone who's supporting the show on the Patreon. It's really helping to defray some of the costs of keeping this up and running, both the podcast and the website. And if we can get some more supporters, then I'm really going to start getting those episodes transcribed and onto the website, which is the feature that people have been requesting since the very beginning of the show. So if that's something you're interested in, or you just want to support the show, then please head over to the Patreon. The link is in the show notes, and it's also on the website at www.obgyn.fm. And if there are other features requests, or you just have some feedback, you can always send that to feedback@obgyn.fm. And then the last bit of preamble today is that we have hit a major milestone here at the podcast, and that is we have reached 100,000 downloads for the show. And that's just due to all your support. And so I want to say thank you to all the listeners who have been here for the last 2.5 years, just listening to every show and sending feedback in, and really making it successful. So thank you so much. I cannot wait to get to 200,000 downloads. And thank you all for bearing with me when we have a couple of slow months from time to time for life events. But we're back. And so today we're going to get into a paper that Oystein actually chose for us. The paper is from Lancet in January 2019 and is titled The Frequency of Intrapartum Caesarean Section Use with the WHO Partograph versus Zhang's Guidelines in the Labor Progression Study, a multicentre cluster-randomised control trial. That's a little bit of a mouthful. So, like most places in the world, this paper was done in Norway, but like most places in the world, everyone's concerned about the primary cesarean delivery rate, because that then leads to repeat cesarean deliveries and then further cesarean deliveries, and then the complications that come from that. Now, one of the major causes of that, especially in nulliparous women, is labor dystocia. And how do we define labor dystocia and act on it really comes from work that was done in the 1960s in the U.S. by a man named Friedman. And up through 2010, his work was all that there was. And so we would say this is the normal course of labor, and people either stay on that curve or they don't. And then that was really it until 2010. I think Oystein has something he wants to put in here. Go ahead.
Yeah, Friedman was from, he did his work in Rhodesia. Just want to say. Then known, it was a British colony. It's called Zimbabwe today.
Okay, there you go. I didn't know that.
Yeah.
So then in 2010, Zhang published a new partograph that was really based on contemporary data. Because in the intervening time, we learned a lot more about the normal course of labor, and we also learned that some factors would modify it, such as obesity, age, these sorts of things. And the population, as we have discussed in this podcast, is much different now than it was in 1950 or 1960. And so all of those factors can affect the partograph. And what Zhang found, as compared to Friedman, was that early labor is slower, and that the transition point between early labor or latent labor and active phase of labor is really around 6 centimeters and not 4 centimeters. Now, people took this. I was in residency when this paper came out, and people took this paper and ran with it, and they really started to change how we approached labor dystocia. But no real studies were done to say what that effect really was. And so, like a lot of things in obstetrics, we just ran with it without having any data for us to tell if it was good or not. And that's where this paper comes in. I'm gonna get to Oystein in 1 second. The primary outcome of this paper was whether the frequency of intrapartum cesarean section use for nulliparous women in active labor differed when adhering to the WHO partograph or to the Zhang partograph. And then they did some secondary analysis about safety for the mother and the baby. Now, before we get into the rest of the paper, I actually want to stop and talk to Oystein here, because this paper was done in Norway, where Oystein practices, and I think it couldn't have been done in almost any other place. And so I wanted to stop and ask Oystein, how do you diagnose labor dystocia in Norway? Is it consistent? Is it varied by provider to provider? And what tools do you guys use?
So we normally, or our we have national guidelines that recommends us to use WHO's partogram. And the way that works is that we started when we defined the woman to be in active labor. Originally, the partogram was meant to be started at 4 centimeters, but lately it has been a bit more lenient. So you can also start it when it's 5 centimeters or above, and the normal progression is supposed to be 1 centimeter per hour of dilation, and it's the cervical dilation that defines the progression, not anything else. So for every centimeter, you if there's no progression, you can also have 4 hours without any progression before you call it labor dystocia. And we have something called in the partogram called an alert line and an action line, which is probably a concept we should explain. And the alert line is calculated from the original Friedman cohort, where he based it on the 10% slowest labors, and and it was a colleague or another doctor that created that action line. It was a mean of those 10% slowest, and it was originally meant to allocate staff resources. So if you crossed the alert line, then you were supposed to be transferred from a peripheral ward to a central ward where there were competent staff. However, in Norway we're not too concerned about the alert line. It's more the action line that we are concerned about, and that's the point where we have defined that we need to do an intervention in order to see if the labor can progress normally afterwards, or if we have to do a intrapartum cesarean section. And the interventions we do are amniotomy and oxytocin infusion. And it's a bit different from hospital to hospital what kind of interventions you use at what time. At my hospital, which was one of the centers in this study, they prefer to do the amniotomy before you cross the action line, but some hospitals, they wait until after. And then also the midwives do things to prevent you from crossing the action line, like administering food and drinks and different positioning and stuff like that. So that's basically how we use the partogram.
Okay. And so how far after the action line, when you've done amniotomy, you started oxytocin, how long after that before you would declare a dystocia and do a cesarean delivery?
Yeah, so that's the thing that varies the most. It's completely up to the team that's on call. In
your experience, how much is the variation there?
It depends on the like what Robson criteria there is. If there's a previous cesarean section, like you don't want to augment too much with oxytocin, and if there has been if the woman has had a labor dystocia before, or and of course the fetal heart tracing. But normally you wouldn't call it a labor dystocia before you have had a maximum dosage of oxytocin and had that work for an hour or two at least. Is my impression.
So you would say up to the action line, it's pretty standardized, at least in the 2 places that you've worked in Norway. But then after the action line, it gets a little more variable.
Yeah, definitely.
Okay. And that's going to be important because this study is a multicentre study. They have 14 different hospitals that they enrolled in it, and they are going to count on them to enact either the WHO or the Zhang partograph completely and not deviate too much provider to provider. Otherwise, that's going to color the data. So I think it's important to note that at least in Norway, where you practice, there is at least a decent amount of standardization across centers.
Yeah, for sure.
Right, because in the U.S., this study would never work because everyone's a cowboy and does things their own way. No one likes to be told what to do. Maybe it's the United States, the pathos, but we don't like being told what to do.
And also in Norway, I should probably say that all births are monitored by midwives, and it's the midwives that handle the birth unless there is a complication.
Okay, and that's a big difference, and that's a big difference between really most of the world and the U.S. anyway. But certainly, it does affect who's making the decisions on a minute-to-minute basis.
Yeah.
So let's get into the study a little bit. So they, like I said, they did a multicentre randomized controlled trial. There's some interesting aspects to this. First, so Norway does about 60,000 deliveries a year. They limited the centers that could participate to places that did at least 500 deliveries a year, which even 500 deliveries a year is not that many. You're at a pretty major place now, right, Oystein? How many deliveries do you guys do a year?
So it's around 5,000 a year, and that's considered large in Norwegian standards.
Yeah, 5,000 is pretty big. At Stony Brook, we do a little over 4,000 deliveries, kind of in the same ballpark. And then there are places like UT Southwest and Dallas that do 18,000 deliveries a year. So those are really the mega centers. But, at least a couple thousand a year, I think, is probably... I mean, at 500 a year, you're not even doing 2 a day, right? So...
No,
not that many.
And to be honest, I think, I'm not 100% certain, but I think the one in question that had under 1,000, it was more towards 1,000 than 500. Yeah, if that.
Yeah, I mean, it does make a difference.
Makes a difference.
Yeah. I mean, you also, and they will get into randomization, but it does put a little bit of potential bias in. Because you are assuming that the places who do less are probably doing lower risk women. They're not doing the high risk ones because, again, at least from the paper, women get shuffled pretty well to the high risk centers if they have high risk issues, right? So, if you had too many of the less than 1,000 in one place, in one group and not in the other, that could affect your randomization. Although it doesn't seem to be the issue here. So. They included nulliparous singleton term vertex pregnancies, which is really what a lot of papers look at. I know the CDC and the NIH here in the U.S. are looking at those particular births in general, because if you can stop those women from getting a C-section, then you're preventing a lot of C-sections down the road. You had to be in spontaneous labor, so it was not looking at inductions. And you had to be at least 4 centimeters at enrollment. So active labor under the WHO guidelines. Now, here is where things get interesting. So they took 14 centers. They randomized 7 to using the WHO partogram and 7 using the Zhang partogram. But what's interesting to me is that those hospitals, regardless of whether the women delivering there enrolled in the study, were using either the WHO or the Zhang. So every woman who delivered at that hospital, regardless of whether she agreed to participate in the trial, was still undergoing, either the control or the intervention. If
she was in the Robson 1 category.
Correct. If she was nulliparous singleton term vertex pregnancy, yes. And I think that's interesting. And I don't know that I have an ethical problem with that, but I think it's definitely an interesting thing. So you have these women who are basically, I guess they go to a different hospital, but by showing up there, they don't have a choice but to participate in the study, even if their data is not being collected.
Yeah.
So I don't know. I wanted to know what your thoughts on that were.
Yeah, I thought about the same as well. I can't give you a very good and thought through answer, but I think this is just the way the hospitals said that they wanted to manage and to monitor the patients, and if that was the easiest and in their view the best and most consistent way of doing it, then maybe that's the right way to do it. But what do you think? We tend to, like I said in OB, we tend to leap before we look anyway, and so we will implement a new protocol like this without ever having studied it at all. So is that any more unethical than just changing it for the point of research? I'm not sure it is. It just felt a little funny to me. That's all. Yeah.
I don't know that's wrong. It's just different.
Yeah, I agree.
So obviously, anyway, the people in this, the women and the doctors in this study could not be blinded because the entire hospital, for at least for this subpopulation of women, was using the same partograph, so they couldn't blind anybody. So they decided instead to blind the analysts. So all the data was done, it was all pulled together, and the site was indicated, but the analysts were blinded to which site had one intervention. So I thought that was a pretty good way of removing some bias anyway. Then they talk about the standardized approach to labor, which is what we already discussed about a little. And it really does sound like, Norway, that there is a decent standardization. Now, you're always going to have people get over the action line. People are going to do something a little different than the next person. But it seems to be as standardized as you could possibly make humans be standardized, unless we're robots. So, there's always going to be a little bit of human, I don't want to say error, but human bias in there. But it sounds like this is about as little as you can get. Would you agree with that?
Mm-hmm. Yeah.
Okay. So then we get into the criteria. Again, for those of us who are not familiar with how the WH partograph works, the dystocia is called if the action line is crossed in the first stage. You then you do your interventions. You try to get adequate contractions. If you don't, then you call it dystocia. And then in the second stage, you have 1 hour for the head to descend to the pelvic floor, or 2 hours with an epidural. And then regardless, you have 1 hour of pushing. If it's more than 1 hour pushing, then it's dystocia.
Yeah, and also if you have 4 hours of not any progression, then it's also called dystocia.
Okay. And importantly, and this is what Oystein we touched on a little bit earlier, is that at least in Norway, this is all electronic. So I'm assuming you put it into your electronic medical record, and then it automatically generates the action and the alert in the action line. Is that true?
Yeah.
And so there's, it's a little bit of a backup electronic system prompting the providers to be alerted, to this abnormal labor. And then for the Zhang, it's a little bit different. So what Zhang did, if you look at his paper, which you can put in the show notes, is that you can calculate how much someone should dilate each hour from what their previous dilatation was. And what they found is that throughout the 0 to 10 centimeters, it was an exponential increase in dilatation rate. And so, you expect to dilate much faster from 9 to 10 centimeters than from 4 to 5 centimeters. And so you can calculate that, and that's what they did here. And then for the second stage, you had 1 hour and 45 minutes to descend without an epidural, 2 hours and 20 minutes with an epidural, which, at least in the 1 hour and 45, is a lot different than the 1 hour for the WHO. It's almost a twofold difference. And they kept the 1 hour of pushing. So, similar in that phase. The Zhang was not incorporated into electronic medical record, and so that was paper. And that is one of the limitations they're going to talk about, is that here there is no electronic system that's alerting you to someone who is not progressing normally. You have to actually put it on paper and look at it yourself. And I think you're working at one of the hospitals that used Zhang's partograph. Did you work at all with this?
No, I started afterwards, but I talked to the midwives and also the consultant that was coordinating the study from our side. And the midwife that I talked to actually said that they found it easier when they plotted it on paper than when they did it on electronic medical records. But that's anecdotal. Yeah. But she said that she was told by her colleagues that was easier, and they were more alert that way.
So at least it wasn't harder anyway, and maybe it was better. Interesting. All right.
In the start, they had some issues with the calculations that they had to go over the calculations and they found it a bit difficult at start. But then after the initial phase, it went smooth. They said.
Importantly, I think, and this is something I taught the residents when we were still using Friedman's, was that for the WHO and also for the Zhangs, when they're talking about an abnormal progression, for the WHO, it's less than 90th percentile or 10th percentile, whatever you want to call it. And for Zhang, it was 95th percentile. So for them to be abnormal labor progression, it's super abnormal. Like it's the bottom 5 or 10% of people progressing. So it's not like they're slightly off of the average. They're way far down. And so it's really abnormal.
Yeah, although the alert line is the 10%, and then the action line comes 4 hours after that. But I haven't. I tried to read the paper where they calculated the action line, but it wasn't accessible to me. So I don't know. I don't know which what percentile the action line is on the partograph. But the 10%, that's the alert line. So that's the first.
So that's still. No, it doesn't. But that's still 90% of people will be dilating more than that, right? So it's the bottom 10 percentile, right? So it's at the very abnormal.
Yeah, but we don't pay that much attention to the ones that cross the alert line. That was more to get the women from one health center to the next. We're more alert to we're more attentive to the action line.
So the action line is probably even lower than that. It's probably 5th percentile or something even lower than that, right?
Yeah, exactly.
So, again, if you've crossed that line, your labor is very abnormal.
Yes,
that's my point.
Yeah,
right.
True.
Once diagnosed with dystocia, this is what like Oystein said. They do artificial rupture of membranes. They start oxytocin, and then some places in the study they say they do ARAM first, and then 1 hour later they would start oxytocin if not adequate. I'm assuming that was followed.
And I did. Yeah, and I did. That's one of the comments they had, that they were a bit before we used to do that before the action line, but now before they crossed, but now we had to do it afterwards. Yeah.
And then if they still did not become adequate or progress, then they would go to cesarean delivery. So, for the sake of argument, we'll believe that all the institutions followed the same protocol and followed it to the letter. So then their primary outcome was frequency of cesarean delivery. Their secondary outcomes were frequency of operative delivery, ARAM, oxytocin use, blood transfusions, these are maternal and neonatal outcomes, APGAR score, pH less than 7, which we had a whole podcast about that one, so APGAR scores 2 for that matter, episiotomy use, and perineal laceration. Their sample size, they went back and they looked at, I think it was 100 charts, and those women were all treated under the WHO partogram, and they reviewed all the charts and said, if we had used Zhang, how many of these women would not have had a C-section? And they said that 25% of those women would not have qualified for a C-section for dystocia under Zhang, who did under WHO. And so they used that 25% to do their power calculation. And I'm going to come back to that in a little bit. So they calculated they would need 6,582 women in their study in order to show that 25% difference. Interestingly, that's 10% of all births in Norway for a year. This study actually went over 2 or 3 years. But still, that's a significant portion of deliveries in one country that they were trying to capture, which I just find impressive. All right, so getting into the results then, they recruited women from December 2014 through January 2017. They found 11,615 women to be eligible. They enrolled a little over 7,000, and they included 3,305 in the control group and 3,972 in the intervention group. Going back before the study started in 2012, they looked at the section rate in both hospitals, both groups of hospitals, and it was 9.5% in the control group and 9.3% in the intervention group. So then when they went and looked at the same data for now during the study, in the control group they found 5.9%, and in the Zhang group it was 6.8%. So although there was no difference between the two groups during the study, there was a significant decrease in the section for dystocia from before the study into during the study. Then they also looked at some secondary outcomes. There was no difference in any of the secondary outcomes that I talked about: operative delivery, ARAM, augmentation, epidural, any of the stuff. It was all negative. They did then go back and look at, they call it descriptive endpoints. And so they give us some information here, but there's no p-values. And you can make an argument that the study was not powered for any of these outcomes, which is why they didn't try to give us p-values, and that's fine. But they do talk about it later in the paper. So,
I don't know why they didn't call it secondary outcomes, why they didn't group it together. It was just a bit confusing that they had primary, secondary, and descriptive endpoints. But
so they did find that there were less women who underwent a C-section for labor dystocia before 6 centimeters with Zhang, which kind of makes sense because Zhang is much more permissive of the latent phase of labor. They consider active to be 6 centimeters to 4 centimeters. They're a little less strict in that sense. So it kind of makes sense to me that they would have less sections there. But like I said, interestingly, there were no difference in the overall section rate. And again, even that difference before 6 centimeters, but they don't give us p-values, so I don't really know if it's significant or not. But it is descriptive, as I said, so maybe there's something there. So I said I wanted to go back and talk about sample size for a second. So, like I said, they looked at 100 charts who had been managed based on WHO. They applied Zhang to it and said, okay, 25% of these women would not have been sectioned under Zhang, and so we're going to use that as our into our sample size calculation. But the problem is that we don't know if those 25% of women who would not have gotten sectioned under Zhang at that time would have ended up getting a C-section, and if they'd followed them longer, and they didn't do that study. So it almost would have been interesting to take 100 women, do the WHO, say where okay, I would have gotten a section now. Don't section them, allow them to go further under Zhang, and then see if they ended up with a C-section. Because then you would actually know what that real delta is between the two. Because I think what happened is they very much overestimated the effect that Zhang may have on the section rate for dystocia, and in doing so, dramatically underestimated what their number needed for the study was. I think if they really wanted to show a difference, they would probably need a lot more women than 6,000. I don't know, what are your thoughts on that, Oystein?
Yeah, you might be right. And the only thing that I thought of with the power calculation was that maybe they thought that the ones that had gotten a C-section after 6 centimeters with the WHO partograph, they would have gotten it with Zhang anyway. And the ones that had a cesarean section before 6 centimeters, maybe some of those would not have ended up with the cesarean section with Zhang. I don't know if that's what they thought, but
I just think that I think you're right. I just think that the 25% is probably just off. Now, is it really 20% or is it really 5%? I don't know, but I think we probably need some different study here to figure that out.
Yeah, sure. Because what they lose is they lose the ones that progress to a normal birth and would have had a protracted labor with Zhang.
Right.
If that makes sense. Yeah.
Anecdotally, some of our midwives, they don't do WHO and they don't do Zhang. They do like the midwife partograph, and they'll be fully dilated for 8 hours. And some of those women will end up with a vaginal delivery. Now, we could argue whether that's good or not. All right. But they do. And so you really can't compare two different women. You have to really compare the same woman. And the only way to do that is to I guess really actually manage them under Zhang and then go back and see if you would have sectioned them under WHO. Like almost the opposite of what they did.
Sure. And elaborating on that, like what they did find, probably, even though you said that they didn't have a p-value, was that there was a difference between the cesarean sections in 6 centimeters, but then they didn't find one overall. So maybe that's what screws up their power analysis, that they had a difference between or below 6 centimeters, but that doesn't make a difference because there's maybe you get the impression that the other cesarean section comes after 6 centimeters, or they have to, So that's maybe why so maybe that's why the power analysis, maybe that was wrong based on that. Yeah. If that makes sense.
I think it does. So they talk, in their discussion and then in their limitations, a couple of things. One thing I found very interesting is that even though they didn't find any significant difference inside their study, they did, like I said earlier, find a significant difference between pre-study and study. And what they think is that really probably has to do with the observer effect. Like all of these hospitals now they had to follow the WHO partograph all the way to the letter, and they had to follow the Zhang all the way to the letter. And so just by doing that and observing them and being heightened about it, they were able to reduce the section rate from 9% to 6%.
Yeah, which is interesting. Yeah, no, I think it makes sense. That's And that tells me that there is that you have some quality improvement jobs that you can do in different hospitals in Norway to get people to adhere to the guidelines more rigorously.
Now, what would have been interesting, and they didn't do this, is to look at the 2012 data for maternal and neonatal outcomes and see if there was any difference between that data and the study data. Right,
but the study is too small, don't you think?
Probably, but
the perinatal mortality that's just the mortality rate, but that was probably not what you were talking about. But
I would be looking at, I suppose, not that I really think Apgars and pH are great indicators for fetal health, but you can look at that stuff in transfusion and stuff. Because sometimes we get so caught up in vaginal delivery being the best thing that we lose sight of other things, right?
Yeah.
So just because the section rate went down by 3% doesn't mean that that's necessarily good. Now, it probably is, and there probably aren't any bad outcomes, but we should check before we jump on that.
Yeah, I agree.
So, I actually kind of want to take this... I don't really care, WHO or Zhang. I kind of want to take one of these and implement it at a hospital here in the U.S. and see what we can do with it, right? Because we have section rates that are in the 30%, right? Overall section rate 30%. For dystocia, it's lower than that, but probably 10 or 15%. But see if we can get that down just by implementing some standardized way of declaring when someone has labor dystocia. I think that would be fascinating.
Yeah, it would.
Yeah, so basically we just need to make the U.S. like Norway, and we'll be all set.
Yeah. Pros and cons with everything.
Yeah, fair enough. The only other limitation they really talk about in their limitations is the paper for Zhang and the electronic for WHO, which we already discussed. And again, they just really point to the fact that if you can prevent a C-section in a nulliparous woman, you're then preventing her repeat number 1, repeat number 2, repeat number 3, right? And therefore, you're hopefully preventing uterine rupture if they try of labor. You are preventing accretas and all the hemorrhage, transfusion, all the stuff that goes along with cesarean deliveries. So I think they're, it's a very important topic. I really, although I have some quibbles with how it was done, I think it's an amazing study. I'm really impressed that they thought of this, funded it, and were able to do it. And I think it speaks a lot to the nationalized healthcare in Norway that they were able to do that.
Yeah, I was also very impressed with the way the study is written. We haven't talked about that, but it's very clearly written, and it's a delight to read. Even though we've talked about some things that we would like to have elaborated a bit more on, but I thought in general it was very clearly and well written.
Absolutely agreed. It's funny. I'm reviewing a paper now for a journal, and there's a whole section of it where they get into some statistics and they do some regressions and whatnot. And I understand the tools that they're using, and I have no idea what they wrote in this paper. So sometimes it's difficult to take complex statistical models and talk about them in a way that is, plain to the people who aren't engrossed in that kind of stats. And honestly, most clinicians don't have a very big background in stats, and so you kind of have to spell it out for them a little nicer. And they did a nice job here.
So what are your, I'm taking your job from you, but
go ahead.
What would you take away in your practice from this study?
I think what I was saying a few minutes ago, I think that there probably isn't a huge difference between WHO and Zhang, at least in the final outcome. I think there's an issue when they get sectioned, and you can make an argument for, yes, there are some women who, if you don't section them at the WHO line, will end up progressing to a vaginal delivery, and so you are saving a few C-sections. But there are also women who aren't going to get sectioned until later under Zhang, who maybe get chorioamnionitis or something else that they wouldn't have had if you did it a little earlier. So I think there's pros and cons there. None of that was in the paper. That's just me talking off my head. But I think that just having a standardized way of doing it seems to me to be the real thing here. And that really isn't a surprise to anybody, including myself, that when you standardize things, you get better outcomes. But this really drove it home for me.
Yeah. What I would take away, practicing like that, since we use partographs, I thought it was really interesting with that there was like we talked about, that there was a difference probably between when the cesarean sections were done, and I would hope to see another study that looked a bit more into that, because like if you do a cesarean section later in the first stage rather than earlier, you have bigger risks of bleeding and infection and every sorts of complications. And what I'm a bit concerned about with this or with the Zhang curve is, or partogram, is that do we do a cesarean section on the same amount of women but do a riskier cesarean section compared to the WHO partograph if you would start to use the Zhang partograph? Because in when they did the study here in Norway, or in Stavanger where I worked, there were a lot of hope that they could switch to the Zhang partograph, because to the midwives and to the doctors it makes more physiological sense that you can have more time in the start, and then it should progress faster after that. But I don't know. What do you think about that?
Yeah, I think that as long as there aren't worse outcomes for the mother and baby, I think that that's fine. Now, I think what you were saying a second ago is that a lot of those outcomes are rare enough that in order to really prove a difference like that into maternal or neonatal morbidity, you're going to need a lot more deliveries in order to show that difference, which also may actually show you that the difference isn't that big anyway. But I agree with you. I mean, doing a C-section at 4 centimeters is a lot than doing a C-section at fully dilated for 2 or 3 hours, right? A lot less risk at 4 centimeters, less risk of extension for hemorrhage, atony, all those things. So I don't know. I think we need more here. Maybe you can talk to your colleagues there and recommend that they go back and look at the ones who were managed under Zhang and applied WHO to them and see what the difference might have been as far as section there. I think that might be interesting, and they have the data already. Yeah, that was also a thing that I wrote in my notes preparing, was that if it would be interesting to compare the partographs and see if they were different if you used the other partograph in the ones that were included in this study. Yeah, and I think the other couple of other data points that may have been interesting is for the women who had a C-section, what was their time in labor before the C-section for both groups? That might be interesting. And the other thing they didn't really give us here is the rate of chorioamnionitis in these women as well. Yeah, they did give us the duration of the active phase of labor. It was it was 6 hours in the WHO group and 6.6 hours in the, or if it means 6 and 59 minutes, I'm not quite sure. It looks like it's a comma. Now, was that for all the women in the group, or was that just the women who had a delivery for dystocia? Good question. I think it was all the women. I think it's all the women. Yeah. Yeah. So I'd want to see what it was for the women who had who had a section for dystocia. I think that would be the number that would be interesting. Yeah. No, I gotcha. Yeah. And anyway, a very thought-provoking article. I want to thank you for looking it up and sending it in, and then also agreeing to spend your night talking to me about it. I really appreciate it. No, I appreciate coming on, and it was interesting to discuss the paper together with you. All right. So I think we're going to wrap it up there. As always, the paper and all the relevant papers that we talked about, which for today will be probably Friedman and Zhang, will be in the show notes, so you guys can go look at them when you want to. Otherwise, thank you very much for listening to the Journal Club for February 2019. Like I said, feedback at obgyn.fm if you want to send some notes into us, tell us what we got right or what we got wrong. The Patreon is also on the website. You can check that out. And please, if you have a few spare dollars to send to the show, that would be great to help pay for what we do here. Otherwise, we'll be back next week with a monthly checkup. And until then, thanks for listening.